Thanks so much for joining you. Taking a slightly different angle with my presentation. I'm not necessarily going to be talking about the specifics of studies, but really put you into the context of my environment, which I find myself in, which is working with people with a spinal cord injury. So I'm going to cover physical activity considerations for that particular population group. Because the topic is around transitions, what I wanted to share with you, I guess, like I've mentioned, is the population group that I work with. So here on this slide, it shows you the recovery time for someone with a spinal cord injury. The main aspect around, again, today's topic is very much around body composition and appetite. So really what I want to just share with you is there's a larger portion of someone who obtains a spinal cord injury by trauma of bed rest. I know that's obvious to many people, but obviously you have that immediate phase in terms of emergency spine stabilization and acute care in emergency aspect, following through to the first few weeks, looking for some stabilization, moving into the subacute rehabilitation facility, through to the first year of physiotherapy, etc. So there's a couple of different pathways that we can be talking about. The first one is bed rest through to physical activity, but also in the world which I work in, which is actually sporting performance, is we have bed rest, physical activity, sports, and possible retirement from high performance sport. So they're the various transitions that I'm hoping just to give a little bit of a snapshot and share with you today. So in terms of facts and figures, there are an estimated 60,000 people in the UK living with a spinal cord injury. And if we have a look at this slide that I'm sharing with you here, then we can see that on the top, I have an image of someone from a DEXA, the bone mineral density, MRI scan, an able-bodied illustration, versus that of someone who has an incomplete spinal cord injury 6 weeks post-injury. We can see physiological adaptations have taken place, a decrease in muscle volume, there's an increase in percentage body fat, risk of fractures, etc. And there's a whole array of things that happen in terms of autonomic function and from regulatory aspects as well. So there's big physiological consequences that occur as a result of a spinal cord injury. In terms of the mobility that the person usually will actually require when they leave into the rehabilitation community phase, is actually using wheelchair as a form of locomotion. If you have an incomplete spinal cord injury, then there may be some individuals who actually use crutches, walking sticks, but primarily individuals may elect to use the wheeled mobility as a requirement for their daily activities. Now, this is very important for them to maintain their physical activity, but what I must stress is that this as a form of locomotion is very inefficient. And again, if we're balancing and looking at energy intake and the energy balance, we need to consider that these individuals are using small musculature, and hence there may be different margins in terms of the energy expenditure based on the exercise modality. So moving back onto transitions then, if I look at the nutritional knowledge of persons with a spinal cord injury, it's going to be greatly influenced by past experiences, the transition of being an active individual to becoming someone paralyzed. And again, that's going to be related to different circumstances. And if I look at this image to the right here, we have an individual, maybe like you and I, very active, able-bodied, with someone against them as a spinal cord injury. We do need to consider quite significant alterations, but I consider them to be subtle, and they are indeed some modifications to normative data. But is there normative data out there for persons with a spinal cord injury? That is one of the questions. The guidance may vary from spinal cord injury rehabilitation centre site by site. Some spinal cord injury centres specialise in different knowledge. Some may have more knowledge with respect to nutrition, appetite, and others may have more emphasis around using modalities of functional electrical stimulation, respiratory training. So specialist pockets of knowledge in spinal injury rehabilitation advice. If I look at energy balance, then exercise type, the type of modalities that are being used, is a topic of great interest, and there's been lots of work that has recommendations around physical activity, sports as exercise types. But if I look at appetite regulation, which is known here at Loughborough University as one of our topics of research interest, then there's not much known around appetite regulation for persons with a spinal cord injury. That has actually led to some recent work by James King and other colleagues that was undertaken at the start of this year and the end of last year, which we're moving forward as a research theme of one of our PhD students here at Loughborough University. If I look at my environment, which is sport, then we look at the demands of the sport and training. And here, just on this slide here, we have a wheelchair tennis player, an able-bodied tennis player in the running game. We have a wheelchair rugby player. We then have rugby, we have hand cyclists and cycling, we have basketball, wheelchair, and the running version. And clearly, hopefully you can just see from this, which is quite obvious, really, because of the modality that is being utilised and the person who is paralysed, is that there is less kilocalories per hour in that sporting environment that person needs to be achieving compared to the able-bodied comparison from a sports and training perspective. If we look at the physical activity benefits for people with a spinal cord injury, then again, they are just like you and I, where basically we obviously do physical activity to gain better fitness. It then allows easy activity of daily activities and living. There's a decreased risk of heart disease and diabetes. There's less pain, better psychological well-being, improved social engagement, and obviously we're going to hopefully reduce the burden on the NHS in terms of the healthcare. Now, they're all well documented in the literature, and they're just the same as physical activity for anybody, really. But what I just draw your attention to is the asterisk I put by less pain, is we do need to consider the types of exercises that we are prescribing to patients and people in the community around the exercise type. The wheelchair, like I've mentioned, is a key factor, but we may be looking to encourage people to do arm crank exercise, hand cycling, to take the risk of injury from the shoulders and from the wrists, and obviously have some varied activity that we want to be including. That in mind, however, that is going to offset maybe the energy expenditure from the activity, because some modalities are more efficient than others, and there's a counterbalance between trying to accrue to a certain degree, increase energy expenditure, but we've got to weigh up the cost of that to maybe injury risk and pain in the shoulders by doing wheeled mobility. If we look at the general big social psychology aspect around people with a spinal cord injury, then a colleague at Loughborough, Anthony Papa-Thomas, has done some great work around looking at the insights from a narrative perspective of barriers to activity. And this slide really just shows it quite obviously, really, where someone is parked their car onto the pavement and an individual just can't partake in physical activity and go out and get their newspaper because they can't pass on the foot pathway. So just the main aspect of my slide, I'm quite trying to be quick really, is I'm just putting now a case for spinal cord injury exercise guidelines that are specific to the population. But what are exercise guidelines? Hopefully all of you that I see your names in the audience know about exercise and physical activity. And obviously we do need to make sure that they are suitable for age, sex, the ability specific. And obviously we want to have those to enhance fitness, performance and health. So over the last 2 or 3 years, I've been working on an international project with UBC. And we've basically been looking at the scientific evidence around putting together exercise guidelines for adults with spinal cord injury. One of the key outcomes of the data, the systematic review that we were looking at, was body composition measurements, and that was around fat mass and fat-free mass as key primary outcomes. Now, the scientific guidance that we came to was, in order to improve cardiorespiratory fitness and muscle strength benefits, we would like to encourage individuals to undertake 20 minutes of moderate to vigorous intensity aerobic activity 2 times per week, and 3 sets of strength and conditioning exercises 2 times a week. However, to push things up to the cardiometabolic health, we'd really be looking to encourage people to partake in exercise for 30 minutes per week for 3 times per week. Now, why are these SCI guidelines less than the WHO guidelines? The main aspect is really that persons with the spinal cord injury, the guidelines that we have developed are based on minimum dose, whereas the WHO have based an optimal dose. People with spinal cord injury are starting at a lot lower level of fitness than the general population. Moreover, if we challenge that, why do we have a different phase of guidelines, moving from 20 to 30 minutes, 2 times to 3 times, then there's a lot of evidence in the literature that is suggesting that we need that greater stimulus to improve the cardiometabolic risk factors. Mechanisms of cardiac metabolic health improvements in people with spinal cord injury are still poorly understood. And we do need to look for more stronger evidence when we're trying to distinguish, are we gaining fitness benefits over cardiometabolic outcomes? And for those who would like to know more about this, I just guide you to this website, and hopefully the slides can be shared for you to have a look at this website or further background to this particular project. So just moving to the closing thoughts then, the key aspect of working with this unique population is really that we must understand the physical impairment and indeed the physiological consequences if we're looking for some nutritional guidance for this population group. We must undertake a full medical diagnostics. We must have a look at the function and movement pattern and previous injury, illness, and previous knowledge of the participants. If they were an athlete, they obtained their injury on a rugby pitch and then they become a wheelchair user, then what evidence and knowledge base are they gaining to have a look at their energy balance? Evidence-based practice and the research out there is essential. We must not neglect, however, the anecdotal evidence that comes from the practitioner, the clinical experience, and indeed the person themselves. Much can be shared across and between rehabilitation, exercise, and sports scientists. The knowledge and medical provision for persons with a spinal cord injury has improved. And I think that has improved by working in a multidisciplinary perspective and adopting indeed an interdisciplinary fashion as well. And that's a key aspect I know that David and Carolyn are trying to achieve from today's presentation. I would call myself a sport and exercise scientist, but over the last few years, I've been working in the domain of exercise and physical activity as well. What I must stress that no one size fits all, and we must not adopt that when we do work with specialist populations, such as persons with a spinal cord injury. For example, don't compare Paralympic athletes is what I would say, but don't compare persons with a spinal cord injury to normative values. This is the same across the exercise continuum and during those transition phases. I've not gone into too much key depth around those transition phases, but as you can see, sport may have trauma, that may lead to bed rest, that then leads to a change of body image, the psychosocial aspects, getting back into physical activity, possibly going down the journey of sport, exercise, high performance. Who knows where that pathway goes, but our journey is to try and support the pathway at any of those transition phases. Thank you very much for your attention. Apologies for the minor error, and that will get me set up for my teaching later this afternoon. Thank you.
Thanks, Vicky. That was great. Really appreciate that.